Kesimpta is a new drug approved by the FDA for multiple sclerosis. Dr. Gabriel Pardo MD, who is with me here, was on that research team and knows the ins and outs of the drug. And he and I are going to chop it up for all the folk who are curious about the drug right now. So talk to me about Kesimpta. Why is Kesimpta different than other therapies on the market right now?
Well, I think that the first thing we need to talk about, Damien, is the fact that we are very happy that we are having more and more options to treat multiple sclerosis. Look, this is the consequence of a large MS community interested in this disease, understanding what's happening in MS. So essentially what we're doing is that we're understanding the roadmap better. As we understand the mechanism of disease, what happens in MS, and we lay that map out, then we find ways to put roadblocks in that process, right? And eventually what we want to do is to eliminate the consequences of this abnormal immune response that attacks your own body so that we improve the quality of life of patients by decreasing the presence of new events, relapses, and inflammation. And Kesimpta is one of the options that we have that is leveraging a very novel approach in the sense that in the immune system mechanism, there are different players, there are different actors. The way in which I like to think of this is like our armed forces for the country. And we have the Navy, and we have the Army, and we have the Coast Guard, and every single one has a different function, even though the ultimate goal is to keep us protected, right? The immune system does the same thing for us. And there are different players, different parts of the armed forces. One of those is called the B cells. So lymphocytes is a group of cells in the immune system, and we can divide them in two big groups, T cells and B cells. And Kesimpta is a medication that targets specifically the B cells. Now, there are other medications. There's another approved medication in MS that has a similar mechanism of action. It targets the B cells, takes them out of commission. But Kesimpta has some peculiar characteristics that differentiates it from the other anti-CD20 treatment that is available. For example, Kesimpta is administered as a subcutaneous injection, so the patient will be able to do that by themselves at home. It's a monthly injection. Once a month you have to inject, as opposed to the one that is already available, which is an intravenous injection. Now, that one has a lower frequency of administration. That is ocrelizumab. It's only administered every 6 months. So some things, better depending on the preferences of the patients and the characteristics of patients and healthcare economics, so many factors that play a role. But those are some of the basic differences between Kesimpta and other medications available for MS.
Got it. So it's like the new hot kid on the block right now, essentially doing the same thing differently in the convenience of your own home.
Well, that's a good way to put that. Yes, sir. It is indeed the latest medication available for MS, the latest one approved for multiple sclerosis. And it does have some novel characteristics to it based on a known mechanism of action. So we have used anti-CD20s before. We know they work. But then independent from that, Kesimpta was a medication that actually did its own clinical trials. It was studied very carefully, and we have very good data regarding what are the benefits of the drug, as well as the potential side effects and safety concerns that we have. So very well conducted scientific studies that allowed us to understand that medication in its own right.
So if this works on B cells, how does this differ from other medications on the market? Is it just that this is the first one for B cells that you can take at home?
Correct. So there is one other that is anti-B cell, specifically what we call anti-CD20. So to kind of expand on that topic, the immune system we can divide in two broad groups, what we call the innate immune system and the adaptive immune system. And the innate immune system is the one that is in place as a general measure. Let's think of it as the fence around your house. It kind of stops everything and everybody. Not even the mailman can come in, right? So
that's right.
It's a very broad defense mechanism. We have then the adaptive immune system. Now, that one is particular to each individual because it's the one that we develop as we get exposed to things in life. The bacteria, the virus, the fungus, all of that. So it learns. It's the one that learns. It's the one that goes to school in your lymph nodes and learns who are the good guys and who are the bad guys. That is the adaptive immune system.
Got
And
it.
the B cells are part of that. T cells and B cells are part of the adaptive immune system. And even though we have conceived MS historically as primarily a T cell mediated disease, meaning the bad guys are the T cells because they are the ones that ultimately go and do the damage, we have come to learn that the B cells play a very, very important role in the mechanism of disease and MS. And if we take the B cells out of commission, then we're going to have a significant beneficial effect in reducing the manifestations of MS, inflammation, relapses, MRI activity, all those sort of things. So again, it's going back to, do we know the roadmap? Can we put the roadblock? So we're putting the roadblock on B cells, which is only part of the entire process, but good enough to have a significant effect on the ultimate results.
Right. So other medications do target B cells as well. So how does this Kesimpta stack up against what's already on the market?
Right. So there are many different medications and they have different mechanisms of action. Some other medications will have, for example, an effect in what we call the blood-brain barrier, which is a very tight area. Yes, sir. The blood, as blood flows through our body and goes into the brain, it actually does not go into the brain tissue. It just goes in and out and is able to bring nutrients and oxygen. And it's a very tight, like a gateway. And immune cells can breach that gateway and go into the brain, and that's when they create problems. So we have another medication that all it does is to minimize the risk or the ability of the cells to go through the blood-brain barrier and keeps them in the circulation, but they do not allow it to go into the brain. We have other cells that change the proportion of good cells versus bad T cells. So they work in many different ways. Now, there is one other medication that is specifically an anti-CD20, just like Kesimpta is, so one other. And the difference between these two, very basically, is that Kesimpta is administered subcutaneously by the patient as opposed to the other one that is IV every 6 months in a medical facility. And the doses are different and the frequency of administration is different. Now they have, when you ask how do they stack, we have not studied them head to head, so we do not know exactly how they compare. When Kesimpta was studied, it was studied against another approved medication for MS, but not another anti-CD20. It was compared to something called teriflunomide or Aubagio.
That's Aubagio.
That's Aubagio, yeah. That is what we call an active comparator. So when we do studies in MS, I mean anything in medicine, we need to have an outcome. How do we measure the benefit, right? And we need to compare with something. If we're not comparing with something, how do we know if this is working and it's only by chance? So historically, at the beginning of the evolution of MS research, we were doing trials comparing to nothing, to placebo. So patients would get an injection of drug versus an injection of water. And that's how we did our initial trials. Now, over time, that became actually unethical, because if we have approved medications, it will not be appropriate to test people with no medication when we have known approved medication. So the second wave of research in MS in clinical trials, we started using active comparators. So we compare the new drug against an established drug. And that is how Kesimpta was studied. It was studied against an active medication, which is Aubagio, which is taken by mouth in what's called a double-blind, double-dummy design. What does that mean? So double-blind refers to the fact that the patient does not know which one of the two medications they're taking. And we, as researchers that are taking care of patients, do not know either. So both of us are blinded. The patient and the treating physician are blinded, so double-blinded. Double dummy means that the patients were as if they were taking both medications, but only one was the real medication. So for example, everybody was doing an injection once a month and taking a pill once a day. Now, either one or the other was the real deal. So half of the group was taking the real pill and water injection, while the other half of the group was taking the real injection
doctor.
And a sugar pill. Yes. So that's the double dummy, double-blind design of the study, which guarantees objectivity. See, the purpose of all of this is to eliminate bias, because if we're trying a new medication that we believe is better, you as a participant, as a patient, might be biased to believe or feel or think that you're doing better, and same for us. So we want to eliminate that. We want to make it as objective as possible. So it was a very well-designed trial with very good scientific basis.
So how does one it's a leukemia medication, right? So how does one take the leukemia medication and then start to put it with multiple sclerosis folks?
Right. So you're right that ofatumumab or Kesimpta is what we call a monoclonal antibody that has been available and approved for quite some time, many years, in a different formulation as an IV at higher doses with the name of Arcera for a type of leukemia, CLL, or chronic lymphocytic leukemia. Well, the key to that is, Damien, that leukemia is a cancer of the blood and specifically affects the B cells. And you heard me say earlier how this medication is a medication that targets B cells. Now, B cells in a MS patient are not going out of control to create leukemia. They're just going out of control in a way that they are affecting your own body by creating autoimmunity. But the actors, the bad players, are the same. In leukemia, they just start reproducing themselves too fast and they create too many of them, and you have to take them out of commission. So targeting them to kill them is a way to treat it, and that's the Arcera version of the medication. But also treating or taking out of commission B cells for the purpose of MS is effective because they're one of the ones that are creating the process of damage. So that's why it's used at different doses. It's not the same dose, even though the mechanism of action is the same, because we're targeting the same bad actors.
I paused because I'm like, that actually makes sense. And I'm really glad a bunch of people in the lab with white coats was working on making that happen.
Yeah. It makes sense. Actually, it's very nice when it makes sense, right?
It is nice when it goes that way sometimes.
Yes.
I'm sort of looking at questions from the viewers. And will this be effective for primary progressive MS or just relapsing remitting?
So very good question. And at this point in time, the approval is only for relapsing forms of multiple sclerosis. The other anti-CD20 medication that is available, Ocrevus or ocrelizumab, did a study in primary progressive MS and found that it was effective. Actually, it's the only approved medication for primary progressive MS is Ocrevus. And when you hear us say that they work in a similar way, they are both anti-CD20s, of course, one will expect that Kesimpta might work also for primary progressive MS. Now, the studies have not been done, so we do not have evidence of that at this time, and it's not approved for primary progressive MS, only for relapsing forms of multiple sclerosis. But certainly, it's a very interesting question and something that needs to be looked into.
Yeah, okay, so a lot of things with injections, you kind of run out of injection sites. Is that something that that this portion of the medication, like that you ran out of injection sites 10, 15 years ago with that medication? Right. Now it's 2020. Do you have any solution?
Well, so there are some different, so look, when we talk about injections in the MS world, of course, we're going to think about our older initial medications that have served us well, the interferons and the glatiramers, and those were injections, either subcutaneous or intramuscular, with much higher frequency. I think that's one of the big differences with our previous MS injectable medications that were given either daily or every other day or 3 times a week or 1 time a week. Those were the Betaseron and Rebif and Avonex, all those, and Copaxone, those type of medications had that frequency of administration. Kesimpta is only once a month. So regarding injection sites, running out of them, the frequency at which we administer is much lower. It's only once a month. So that you have a lesser chance of running out of sight, so to speak. And we have several locations. You can use your thighs, you can use your abdomen, you can use, so different, yes, exactly right, those locations. So we have multiple locations, and with the low frequency of administration is going to be certainly a favorable thing. Beyond that, something else that was looked in the trials, in this Asclepius trials, was the frequency and the severity of injection site reactions, because we knew that from previous medications for MS that was an issue.
Those are no fun. They're no fun at all.
But we were pleasantly surprised to learn that the participants in the study really had a very low incidence of problems secondary to the injections. So in that regard, we have good reassurance from the trials. Of course, in real world, we'll see what happens, and people are different, and we'll see how they react. But the expectations, as they are, from the get-go, seem to be very positive and very good.
Well, that's great. You know what I'm going to do? I'm just going to read off the list of questions. I'm
Sure.
trying to sit here like and finesse it. It's like, nah, I got 10 minutes with the doctor. I'm going to run through the list.
Just shoot, my friend, and I'm happy to answer any and all questions you have.
All right. So it's seeming like this once a month injection schedule is more convenient to people since it's at home and not quite twice a year. Like
Right.
a doctor asked me about this and wanted me to ask you about like the convenience. Has that come up in these trials?
So I mean, certainly it's convenient, and it all depends on the patient. And this is why I preach, and a lot of my colleagues do this. This is certainly what we would like to do. The decision-making process when we choose a medication for someone with MS is a joint process. We bring some information to the table, but you as a patient, you as a family member of the patient, bring a lot of information to the table. Your lifestyle, your likes, your dislikes, your fears. All of that is part of the process, right? Because at face value, certainly doing it at home might appear more appealing and can be the case for many, many people. We'll find the patients that say, look, doc, I do not like needles and there is no way that I can inject myself, right?
Absolutely.
So yeah, certainly it is a positive thing. Might be economically more favorable, but it might not be for everybody, right? And that is what we need to keep in mind. And that is why this decision-making process is a joint decision-making. So yes, it can be more convenient. Some other people can think that they do not want to think about their MS, but only twice a year when they get their infusions. And even though they do have to go to a facility, well, it's only twice a year. But all that being said, what we do know and have learned is that, an injection once a month is very well tolerated. It's a relatively low frequency. You can do it in the privacy of your own home. And they have a good system in place to allow you to learn how to use it. It has an auto injector that facilitates the process tremendously. So they have thought of a lot of things to make it appropriate, feasible, practical. And certainly we as physicians, what we like to know beyond all of that, which is all very important, is it efficacious? Does it work?
I love practical and efficacious. Those are the only things that I am concerned with.
That's right.
Good on you for being on the team to keep making this go.
That's right. That's right.
Let's see, what else? Ask about the lag time between Ocrevus and Kesimpta. Is there a B cell threshold that can be determined with a blood draw? So I think this is a question of like, hey, do we switch medications?
How does
this
transition?
work?
Right. How do you transition from one to the next? So if you were to transition from Ocrevus to Kesimpta, and both of them are targeting B cells, the CD20 B cells, yes, we can measure the CD20 B cells in blood. And actually, we know, and this is done in the trials, we want to make sure that that biological effect, what it's meant to do, is effectively taking place. And we know that both with Ocrevus and with Kesimpta, we reduce the number of B cells to practically zero. They're undetectable. So they're gone. Yes, sir. And they will remain like that for weeks, actually for months, weeks to months, but in practical terms, for both of them, is going to be for several months. So when we are transitioning from one to the next, there can be some practical ways to do that. If you are going to go from Ocrevus to Kesimpta, we know that Ocrevus is administered only every 6 months, so we will have coverage in the beneficial effect of suppressing the B cells for 6 months or more. So there will be no need to use Kesimpta during those 6 months if you're going to transition. So around the 6-month mark will be the time at which we'll say, we can go ahead and start Kesimpta. Now, we could measure the B cells, and one could wait for them to start coming back before you administer the drug. In practical terms, for me, that will not be something that we need to do. I do not need to wait for them to be resurrected for me to kill them again, so to speak. When I know that I need to continue the beneficial effect, and I might be opening the door for potential reactivation of MS activity if the B cells are coming back and I'm not suppressing them, if that is the approach we have decided to take. So essentially, I will wait for 6 months from the last Ocrevus infusion, at which time initiating Kesimpta certainly can be appropriate.
You know, I think you may have already answered this, but I want to get this specifically. How do they control B cells? A blood sample? What is your opinion about Mavenclad? Now, you may not be able to, you know, do all that, but that's the question.
Yeah, so we can measure the B cells. So there are different types of B cells, and we essentially, when I say CD20 B cells, is what we call a surface marker. Think of the B cells wearing a uniform.
Right.
So I can, you know, identify the ones wearing the yellow shirt or the red shirt, so to speak. And in the lab, we can do that. We can select and count which ones are the ones that are the CD20 ones. When we think of what we call the B cell lineage or the maturation of a B cell, it starts as a stem B cell, and it goes through different stages, what we call pro-B cell, pre-B cell, mature B cell, all the way to something that we call the plasmablast and the plasma cell. So they mature. Now, of the entire line of, say, 10 stages, not all of them were the uniform CD20. Only some of them do. And those are the ones that are going to be taken out of commission. The stem cells and the early ones do not. And the late stage ones, plasma cells, plasmablasts, the one that produce antibodies, are left alone. We only take out of commission the ones in between. But we can measure that. So to the question that was posed, yes, we in blood can get a blood sample. We can take that to the lab, and we can count how many total B cells you have and how many total lymphocytes you have, and how many of those are B cells. Do you have any, yes or no?
Wow. Thank you. Because that's a good, solid question. And I don't know, but the scientist, Dr. Man, he knows. Let's see what's it. This down here, efficacy, right? For years, like there's different efficacy. There's various medications have various levels of efficacy, right? Is this one of these things that it works for everybody all the time, everywhere, or like what is it? What is the ratio here?
Right. So you're right. So when we do the studies, we need to measure something, what we call the outcomes. What is it that we're looking for? How can we know that a medication works? We have to have a way to measure it. Example, if we come up with a medication to treat migraine headaches, then we count how many migraine headaches you have before you start on drug, and then we count how many migraine headaches you have after you start the drug. Are they going down or not? Simple enough, right? What do we use in MS? In MS, we have certain specific outcomes. Number one, the one that is used most commonly, and for the relapsing forms of MS, is something called the annualized relapse rate, meaning the number of relapses, the frequency of relapses. What is the proportion of people in the time of the study that had a relapse? So the ARR, or annualized relapse rate, is the most common primary outcome, or the main outcome. And yes, we have seen different numbers for reduction of the annualized relapse rate for the different medications. Now, word of caution, we can only compare the efficacy of one with respect to another if we study them head to head. Because when we do independent studies, the population might be different, the definition of relapses might be different, so many variables.
Absolutely.
So we can only compare when we have head-to-head studies, right? But that being said, we can also look at absolute numbers. So for example, for Kesimpta, for the outcome of annualized relapse rate, the frequency or the relapse rate at which relapses were happening for the MS population on this medication, on Kesimpta, was very low, 0.1. What does 0.1? 0.1 translates into having one relapse every 10 years. That is like an easy way of conceive that. So it's a very low absolute number of relapses. Now, when you compare with your active comparator, so against Aubagio, which was the one that was used in the trial, and you say, how much better did these people do with respect to the other group? So the reduction or the benefit, the relative risk reduction compared to Aubagio was upwards of 50% additional benefit than what Obaju is already giving a patient. And we already know that Obaju in its own right is working and it's reducing the frequency of relapses. So it's 50% plus on top of what the other one is doing, so to speak.
Wow. Oh, go ahead.
And there are other outcomes. So in addition to relapses, we also look at, for example, MRI. MRI is a very good, what we call surrogate marker, another way to look at what is the disease activity taking place. And if you have new lesions or if you have actively inflamed lesions, the ones that enhance with contrast. And again, in this trial, when you compare Kesimpta with Obaju that is already providing benefit, the relative reduction of enhancing or active lesions was upwards of 90% reduction of the presence of new enhancing lesions and upwards of 80% of any new lesions in the brain at all. So highly, highly effective in all the inflammatory markers, either relapses or MRI lesions.
Wow. Thank you, because you need to know that. And
yes,
it's great to just speak with someone about it, to turn multisyllabic gobbledygook into words that I understand and words that I can just relate to and speak to a person about. So thank you. There's a couple more things. So there's no pre-med here. So since there's no pre-med, does it change the whole process? Like, how does this work?
Right. So for other medications, especially the infusibles, and for some of the all injectables, we use and continue to recommend the use of pre-medication to minimize some of the side effects that come with the medication. So with the old drugs, for example, the interferons, the older drugs, and I'm not going to call anybody old, just older.
It's older.
Yes.
They had a different birthday.
That's right. That's right. People will develop a little bit of flu-like symptoms following the injection, so we'll pre-medicate them with, like an ibuprofen or a Tylenol type medication. With the IV medications, we can have what's called infusion reactions. So we do pre-medicate our patients with a low-dose steroid, as well as medication for allergies, like a Benadryl type medication, and Tylenol to control any potential fever. For Kesimpta, there is no need for pre-medication. So there were no real side effects to the injections or injection site reactions. So from the clinical trial experience, there is no initial recommendation to use any type of pre-medication for patients that are going to take it.
Okay, that's cool. One less medicine
that's
in
right.
you, because you've got the MS in you and you got the other med in you. Thank you.
Right.
Thank you. So there's no prep work here. That's great. Now this other person has like a couple of bullet points.
Yeah.
Side effects. How long were the trials? What's the medicine made of? What improvements have been seen, and were there people of color in the trials? I don't know which one of those you can answer.
I can answer all of them. Absolutely. So the benefits we talked about. So we talked about the outcomes, right? What is it made of? So this is what we call a monoclonal antibody,
right.
Or MABs, monoclonal MAB, monoclonal antibody. And you'll hear that on the names for people to start learning that when we use the generic name for these medications. If they end on MAB, it's a monoclonal antibody. So Kesimpta is ofatumumab, ocrelizumab, natalizumab, alemtuzumab. All those that I mentioned are MS drugs, and they are all monoclonal antibodies, but they do something different. So what is a monoclonal antibody? It's something that has been specifically designed and engineered to do a specific task. And we can do that in the lab nowadays. I mean, science has advanced to that degree. And if we have something specifically that we want to target, we can design something that will go ahead and do that. So ofatumumab, Kesimpta, is an anti-CD20 monoclonal antibody, meaning it has been engineered to tag cells that express CD20, that wear that uniform called CD20, and take them out of commission. So that's how it works. And that is what it is. It's an antibody. It's a protein specifically targeted to doing that. To the question of minorities in the clinical trial, people of color. Huge, important topic. Look, this is something that we have been certainly aware of in the world of MS because there is less than a fair share of minority groups represented in clinical trials. And this is in general. This is not specifically for this one trial. It is something that we need to overcome. Look, as a medical scientific community, we understand and know that there are some inherited issues. Certainly MS is a medication that is classically more prevalent in females of Caucasian descent, right? So we do not have as large as a population that we have for Caucasians in MS, but we need to make sure that they are represented properly in all of our clinical trials so that we can understand what are the nuances of those type of individuals as it respect to the disease itself and the response to medications. So the answer is yes, they were included, but the percentages are still low. And it is just, I'm just making a little bit of a call to action that we are all aware of in the medical community. No, I shouldn't say that. We're all becoming more aware of, and that we need to act upon that so that we can certainly guarantee a better representation in clinical trials.
Last question here. What is the difference between subcutaneous administration and the muscular? Because one of the people who comments, they have something with their skin. It makes sub-Q a challenge. I don't know what that means, but and I heard some people have been trying to take Ocrevus subcutaneously. However, that's so. This seems to be kind of some mixing matching going on here. Like, does the auto injector take care of this whole thing? Like, what do you do with someone with weak skin?
Yes. So subcutaneous versus intramuscular only refers to the depth at which the injection is delivered. So we have different layers. So we have the skin. The skin has different layers: the epidermis and the dermis, and then those two, those two basic layers sit on top of what's called the subcutaneous tissue. It's essentially a little layer of fat, and we all have a little bit of fat. Some of us have more than others. We all have it. It's all sitting there. And underneath that layer of fat, then we start having the muscle. And the muscle has a covering called the fascia, and then the muscle itself. So depending on the depth or the length of the needle, you are going to get into just inside the skin. That's called an intradermal injection. We do not want to do that for this. Or you can get underneath the skin, subcutaneous in that fatty area. Or if it's longer, then you actually get into the muscle, and that's intramuscular injection. So Kesimpta was studied as a subcutaneous injection, and it has some relevance because the absorption of these compounds varies depending on where it's sitting through the injection itself. And if it's administered subcutaneously, as it was designed to do, it's going to migrate into the lymph nodes where these B cells that we're talking about reside. They come in and out of the lymph nodes. That's what's going to start taking action and taking them out of commission. So that's the ideal mode of administration for this specific one as it was designed. So with the thin skin, certainly, or issues with the skin, if you have skin lesions, a subcutaneous injection might be a little bit of a challenge. If it's just the thickness of the skin, or if someone is very thin, there are ways, and there are mechanisms in place with nurses that will educate individuals how to properly inject. And there are several different tricks to guarantee that the injection actually goes in that subcutaneous space and not someplace else.
Wow, Dr. Gabriel Pardo, a gentleman and a scholar. One, thank you for sticking around with me for my technical difficulties. But two, thank you for going in depth and providing a lot more detail about this new medication, because the viewers are excited about it because they want to, have the best folk on their armed forces, to use your metaphor.
That's right.
So it's a new thing and folk are buzzing about it. And thank you very much for talking with us all about it and alleviating our fears and giving us some more information.
Anytime, Damien. Look, we are all I shouldn't say we're on the same boat. We're all in the same storm. We might be in different boats, but we're here to help each other out. So at any point in time, happy to do it.
Appreciate you. Thank you, Dr. Pardo.